So hello students and welcome to this integrated lectures of neurology. I am Dr. Pradeep Pawar, Professor of Anatomy. Sir, please.
Welcome students. This is Dr. Santosh Patil. I'm your faculty for medicine. And in today's session, we're going to have an integrated discussion on how anatomical knowledge helps us to the medical diagnosis. Okay, so we will definitely go through some clinical scenarios or clinical vignette-based questions, which will help you in next pattern of examination. But how we are going to approach is we will start with understanding the anatomy. Then we will discuss what are the clinical consequences of those anatomical abnormalities. And at the end of the session, we will take one or two clinical vignettes and we will dissect it to the last point of diagnosis. So shall we begin? Okay, over to you, sir.
Okay, students. So I'll begin first with the functional areas of the brain. So I'll just draw the slide for you, the various sulci gyri, the functional areas of the brain, and then we'll discuss about the blood supply of the brain. Once I'm done with anatomy, Santosh sir will be talking on the clinical aspects of this. Okay, so let me begin with this. Have a look at this. This surface of the brain, we call this as the superolateral surface of the brain. Superolateral surface. So students, what is this sulcus here? That's a central sulcus or the sulcus of Rolando. Central sulcus, that's a precentral, the postcentral sulcus, the superior and inferior frontal sulci, the superior and inferior temporal sulci, the parieto-occipital sulcus, the calcarine sulcus, and this is going to be the lunate sulcus. Right, so central sulcus, precentral, postcentral, the superior and inferior frontal, the superior and inferior temporal, parieto-occipital, calcarine, and lunate sulcus. Now, Brodmann has classified these areas into two main types, the functional areas. One is what we call as a primary area. So primary area, and the other one is known as an association area. So whatever information comes to the brain, that first comes to the primary area, right? So primary area is concerned with perception of sensations, to perceive, to receive the sensations. Now, what does the association area do? The association area helps us to understand the type of sensations. To understand is to interpret, interpretation. So the primary area function is perception, and association area, the function is interpretation of sensations. So let me start with the frontal lobe, students. This is area number 4. I'll start with this. Area number 4. So what is this area number 4? This is the primary motor area. Primary motor area. So all the motor input would be beginning from here. Motor output from the brain would begin from here. This is area number 6 and 8. 6 and 8 are known as the premotor areas. Premotor areas. So area number 4 is going to begin the movement. It will initiate the movement, and this movement would be carried out by area number 6. 8 is also known as the frontal eye field, right? So 6 and 8 is the premotor area. 9, 10, 11, and 12 is on the medial side. 12 is on the medial side of the brain. These areas are known as the prefrontal areas. Prefrontal areas. So what is the function of prefrontal areas? Intelligence, memory, ego, self-respect. In short, what is it? Social behavior or personality. So 9, 10, 11, 12 are known as the prefrontal area. And these areas are highly developed in us. We are therefore known as social animals, right? So this is about the motor areas. 4 is primary motor, 6 and 8 is premotor. They will they will actually carry out the movement. Area number 4 will initiate, 6 and 8 is going to carry out the movement. And this 6 is, controlled by what? Which is the nucleus which is concerned with movements, the basal ganglia. 8 is frontal eye field, 9, 10, 11, 12 are known as prefrontal areas. I've told you the functions of this. So coming to this sensory areas, this is area number 312. 312 is known as the primary sensory area. What are sensations, whether it's crude sensation or fine sensations? The track will be discussing after some time. The crude and fine sensations, they come to the brain to this area number 312. So 312 is known as the primary sensory area. Now this is area number 5 and 7. These are the sensory association areas. So what are sensations comes to 312. So if this 312 is damaged, the person is not able to feel anything or sense anything. What is the function of 5-7? It helps us to understand the type of sensation. Now, if this 5-7 is damaged, the person is able to feel, but the person is not able to understand the type of feel. Okay. So this is 5-7, sensory association areas. Coming to the visual areas, this is the occipital lobe, and the visual areas would lie here. This is area number 17. 17 is known as the primary visual area. And what is this? 18 and 19 known as? 18 and 19 are known as visual association areas. So now a person is able to see. So which area is intact? Area number 17. And a person is able to understand what the person is looking at. So what is this area? 18 and 19. So 18 and 19 are known as visual association areas. If this area number 17 is damaged, the person is blind. Okay, that is known as cortical blindness. If 18 and 19 is damaged, the person is able to see, but the person is not able to understand what is being seen. These details will be told to you by Santosh sir. Okay, this is what we call as visual agnosia or word blindness, right? Now coming to this areas, this is area number for temporal lobe. What areas are this? The auditory areas. So this is 41, 42. What is that? These are the primary auditory area. So what information is coming, what we are hearing comes to this 41, 42. 22 is an association area. This is an auditory association area. We also call this as the sensory speech area, or this is what we call as the sensory speech area is the Wernicke's area. So if 41, 42 is damaged, the person is not able to hear anything. Cortical deafness. 22 will help us to understand what the person is listening to. If 22 is damaged, the person is able to hear, but the person is not able to understand what is being heard. And this is what we call as sensory aphasia. So 41, 42 is clear, 22 is clear. So person has heard, person has understood, and now the person wants to talk. So there must be some areas which helps the person to talk. Yes, which are those areas? Those are 44, 45. And 44, 45 areas will help the person to talk. And this is what we call as the motor speech area. Motor speech area are known as Broca's area. Okay. So these are the various functional areas which are classified by Brodmann, which are known as functional areas of Brodmann's areas, the primary and the association areas. I'll just finish with the blood supply also, sir.
Yes, sir. After that, we'll discuss the clinical.
Then you can go to the clinical side.
Yes, sir.
Fine, students. So this is about the functional areas. And now if you can tell me, what is this artery which lies in this sulcus? What is this sulcus of the brain? That's a lateral sulcus here. And which is the artery which lies in the lateral sulcus? This used to be a favorite MCQ previously. So which is this artery which used to lie, which lies in the lateral sulcus of the brain? That's the middle cerebral artery. And if you see this surface of the brain, okay, here, that's the corpus callosum. And this surface of the brain, which surface is this? We have taken a section, that's a sagittal section, that's a corpus callosum. And there's a sulcus here. What is this sulcus above the corpus callosum? Callosal sulcus. And there's an artery which lies in the callosal sulcus. What is this artery? anterior cerebral artery. Anterior cerebral artery lies in the callosal sulcus. The middle cerebral artery lies in the lateral sulcus. Now, this entire medial surface of the brain is supplied by whom? Anterior cerebral artery. The anterior cerebral also climbs and goes to that side meaning a small area here on the supralateral surface is supplied by whom? The anterior cerebral artery. This blood supply is very important. Plenty of MCQs on this. Okay, so the entire medial surface and a small area on the supralateral surface is supplied by the anterior cerebral. The entire supralateral surface is supplied by whom? The middle cerebral artery. The supralateral surface is supplied by middle cerebral. A small area on the medial aspect, the temporal lobe, is supplied by middle cerebral. And what is this then? The occipital lobe and a part of temporal lobe. This is supplied by the posterior cerebral artery. Posterior cerebral artery. So one very common MCQ which used to be asked previously, uh, the occipital lobe is supplied by whom? So occipital lobe is supplied by the posterior cerebral, but the macula is supplied by the middle cerebral artery. So when we talk about blood supply of the occipital cortex, it is two arteries which supply the occipital cortex, the posterior cerebral as well as the middle cerebral artery, right? And if you can tell me the sensory and the motor areas, like look, this is the central sulcus, the pre and the post central. So the sensory or the motor areas, this would be supplied by both the anterior as well as middle cerebral artery, both anterior and middle cerebral artery. And you know the body representation, how is it? It's upside down, right? So the face, the trunk, the upper limbs are on this side, on the supralateral side. The lower limb and the perineum is on the medial aspect, right? So that's about the anatomy, the blood supply of the brain. Over to you, Santosh sir. I hope this is clear.
Okay, so thanks a lot for elaborate introduction to the functional neuroanatomy, sir. I hope that was very helpful to the students. Now let us understand how this anatomical understanding helps us to make a clinical diagnosis. So let me start with one lobe at a time. See, there are two ways to approach the neurological diseases. One, you can approach from the functional aspect, like what are the major functions of the nervous system? One is motor function, second is the sensory function, third, you can say higher mental functions, right? So we can see them as functions, or we can also see them as anatomical locations. The cortex of the brain, subcortical structures, brainstem, spinal cord, spinal nerves, nerve muscle junction, muscle, right? Now let me first address, we will go to the motor system later. Let me address with the one lobe at a time. So if there is a disorder which is affecting the frontal lobe, right, what are the important manifestations that we can see? What are the important areas of the frontal lobe that Pradeep sir has told you? Number one, just anterior to the central sulcus, we had an area that is motor cortex or primary motor area. Its function is voluntary movement. So if there is a lesion, whatever may be the cause of the lesion, there may be a tumor, there may be a stroke, right? Whatever is the cause of the lesion, if the primary motor cortex is damaged, it will lead to loss of voluntary movements, right? So what do we call it as? We can say paralysis. Patients will develop paralysis. Now, weakness will also happen if there is a lesion in the subcortex. Weakness will also happen if there is a lesion in the spinal cord. Weakness will also happen if there is a lesion in the peripheral nerve. Weakness can also be a symptom of nerve muscle junction disorder as well as muscle. How to identify whether a particular patient's weakness is because of a muscle disorder, nerve muscle junction disorder, or is it peripheral nerve, spinal cord, brainstem, subcortex, or cortex? That we will discuss later. Okay. Now, what we will discuss primarily is looking at the individual lobes. Okay, beyond this motor function, there are also other areas, right? So what are the other areas? We have in the frontal lobe, we have a prefrontal cortex. So what is the function of the prefrontal cortex? The function of the prefrontal cortex is personality of the person. That is what Pradeep sir told, right? So if there's a damage to prefrontal cortex, a patient can present with behavioral or personality changes, right? So someone who was an introvert turning out to an extrovert or starting to show up obnoxious behaviors can be a pointer towards a prefrontal cortex lesion. Now, if you ask me, sir, which disorders there will be a damage to prefrontal cortex? there are a lot of neurodegenerative disorders where prefrontal cortex can get affected. Examples I can quote is number one, Alzheimer's disease. In Alzheimer's disease, there can be neurodegeneration affecting the temporal lobe and the frontal lobe. Then you have a condition called as frontotemporal dementia, where frontal lobe is degenerating, temporal lobe is degenerating, so patient can develop dementia and personality changes, right? Similarly, if there is a tumor in the frontal lobe, patient can develop personality changes. One, clear. So we know if there is a motor cortex lesion, patient will present with voluntary muscle weakness, right? Second, if there is a prefrontal cortex lesion, patient can present with personality or behavior changes. Now, what about this motor association area or the accessory motor area that sir spoke about? Right, there is one important function of this extra motor area that is doing. The function is suppression of primitive reflexes. So normally we have some primitive reflexes like rooting reflex, sucking reflex, right, or the palmar grasp, palmomental reflex. Those reflexes we don't show in our adulthood. Those reflexes are gone because they're suppressed by this premotor area. So if there's a damage to premotor area, those reflexes will reappear in adult life. What do we call this as? This will be called as frontal release sign, right? We call them as frontal release sign. There was suppression is released, so we call it as frontal release signs. Frontal release sign is a symptom of lesion of the premotor area. It is a symptom of the lesion of the premotor area. So that tells me that patient has got a lesion in the premotor area, right? Okay, so this is in brief about the frontal lobe. Yes, we will discuss the speech disorders in a separate section. For now, if there is a lesion of the frontal lobe, we can have personality and behavior changes. We can have truncal weakness and frontal release signs because of the lesion of the premotor area, and a motor area lesion will generally cause hemiplegia. Okay, now going behind the frontal lobe, sir discussed about the parietal lobe. Now, what we had in the parietal lobe, just behind the central sulcus, we had the sensory area, and behind that, we had a sensory association area. Now, both these areas come together to give you a higher dimension of understanding of sensation. So, if I touch you, or if I prick you, or if I give you a temperature stimulus, you identify that this was a touch, this was a temperature, this was a pressure kind of a stimulus. But if I ask you to close your eyes and give you an object and ask you to identify, you appreciate it, right? You can say that this is pen, this is a mobile phone, this is glass. How are you be able to appreciating the shape of the object without any visual input? What we call this sign as, this is called as stereognosis, ability to appreciate three-dimensional shape of an object. Similarly, with your eyes closed, if I touch you a particular part of your body, you will be able to localize it. You can take your finger and say, you touched me here with confidence, right? What do we call this as? We call it as tactile localization. Similarly, if I touch you with 2 points, right, simultaneously, you may be able to tell me that I touched with whether with 2 points or at 1 point. What we call this as? This is called as tactile discrimination or 2-point discrimination, right? And if you happen to write on your girlfriend's forearm that I love you with her eyes closed, she will be able to tell you that you wrote I love you, right? This sensation is called as what? This sensation is called as graphesthesia, ability to appreciate written words without visual input. Now, we don't have any primary sensory end organs for identification of whatever I said now, right? For stereognosis, there is no specific sensory organ in the skin. For the tactile localization, 2-point discrimination, or the graphesthesia, there are no specific sensory organs. Then how is the brain getting to know that these are the things that is happening? Because the sensory cortex and the association area come together to process primary sensations to give you these higher level or higher dimension of sensory perceptions. So all these sensations are called as cortical sensations. This is input given by the primary sensation, processed by the brain to give you an idea, and we call them as cortical sensation. And this is a function of dominant parietal lobe. So if there's any damage to the dominant parietal lobe, we will lose these cortical sensations. We will lose the cortical sensations if there is a damage to the dominant parietal lobe, right? Clear? Now, there are 2 more areas in the parietal lobe which I want you to remember. One more area is called as marginal gyrus. Marginal gyrus. The function of the marginal gyrus is, in medical terms, we call it as praxis. What is the meaning of praxis? Praxis means the ability to carry out simple learned movement, right? So if I get angry, I can take my phone and literally throw out of the screen at you. How is it possible? Because I have already learned this simple task, right? This movement is learned by me. If you keep a glass of water in front of me, subconsciously I can go grab the glass and drink, because these are all simple learned movements. If I do damage to the marginal gyrus, then I will lose my ability to carry out this simple learned movement. We call it as apraxia or motor apraxia. Praxis means ability to carry out those movements. Apraxia means loss of ability to carry out those movements. That will also happen if the dominant parietal lobe is damaged. There's one more area in the parietal lobe, which is called as angular gyrus. Angular gyrus. It has some important functions, right? What are the important functions of the angular gyrus? Have you seen the movie Tare Zameen Par? The kid had a disease, right? What is that disease called as? We used to call it as dyslexia. Dyslexia means difficulty in learning. So angular gyrus plays an important role in the act of learning, in the act of writing. So graphia means writing, lexis means learning, and angular gyrus also plays an important role in differentiating between left and right. Because if you ask me, sir, take your right hand and touch my left shoulder, I can do that efficiently because my angular gyrus is intact. If there is a damage to the angular gyrus, then first thing, patient will have difficulty in learning. What we call it as, we can call it as dyslexia, or absolute difficulty, we can call it as alexia. Second, if there is a damage to angular gyrus, patient can have difficulty in writing, right? We can call it as agraphia. Similarly, for doing simple calculations also, angular gyrus plays an important role. Like, I'm not saying calculus and all, like right now we are in physics wala channel, it doesn't mean that everything should be about calculus. For simple basic calculations, 2 plus 2 equal to 4. These are functions of this angular gyrus. So if there is a damage to angular gyrus, patients can lose ability to do simple calculations. 2 plus 2 is equal to 4 also, they may not be able to tell you. What we call it as, we will call it as acalculia, inability to calculate, and left-right confusion. These are the symptoms if there is a damage to angular gyrus on the dominant parietal lobe, right? So far, I spoke about 3 important areas of the parietal lobe: sensory and sensory association area. That was number 1. Number 2, we spoke about marginal gyrus, and number 3, we spoke about the angular gyrus. These are all active on the dominant side of the parietal lobe. They are not active on the non-dominant. So if there is a damage to angular gyrus, it will lead to what is called as acalculia, agraphia, and alexia, plus left-right confusion. And there is a name for the clustering of these symptoms that is called as Gerstmann syndrome. This has been repeatedly asked as an MCQ. Gerstmann syndrome is due to lesion of which of the following structures? It is due to lesion of the angular gyrus. If at all I want to confuse the student, I can set the question in a little different tone. I will give you all these symptoms, and then they will ask you where is the site of lesion, and I can mention the dominant parietal lobe and non-dominant parietal lobe, right? You should be able to tell you that it is when the dominant parietal lobe is damaged, you are likely to see this Gerstmann syndrome. Then you might ask me, sir, there is no function of the non-dominant parietal lobe. If so, can we chop it off and throw it out? The answer is no. Your non-dominant parietal lobe also has important functions. What are the important functions? Number 1, right? If I give you some 3 or 4 cubes and ask you to construct something looking like a World Trade Center, right? Because destruction is not our job, construction is our job. Can you do it? Like put 3 or 4 cubes into a vertical line and make it look like a tower? You will be able to do it, right? Even your kid, or if you don't have kid, when you make a kid, he will be able to do it when he is 3 or 4 years old. How? Because the construction skills are the function of your non-dominant parietal lobe. Then again, don't say that, so if I have superb non-dominant parietal lobe, I'll be able to construct twin Petronas tower. No, the basic simple construction skills using the cubes and all, that is a function of non-dominant parietal lobe. So if there's a damage to the non-dominant parietal lobe, patient will have difficulty in even doing this simple task. He cannot arrange 2 or 3 cubes to make it look like a tower. So loss of construction skills can be a symptom of damage to non-dominant parietal lobe. Okay. Now there is one more important function of the parietal lobe, non-dominant parietal lobe I'm talking about, and that function is, okay, so when I'm talking to you, I'm aware of the existence of my body parts. I know I have 2 legs, I have 2 hands, and various other organs, right? I'm aware of the existence of my body parts. It is partly a function of your non-dominant parietal lobe. So if there is a damage to non-dominant parietal lobe, you might lose the awareness of your body parts. We call it as agnosia. anosognosia, right? Gnosis is the word which indicates you know. Gnosis actually is the parent word for knowledge. So if I say anosognosia, that means you have lost the awareness or knowledge of existence of your body parts. So if there is a question asking you anosognosia is due to lesion of which part of the brain, your answer should be non-dominant parietal lobe, not the dominant parietal lobe, non-dominant parietal lobe. And if I don't know the existence of my body parts, what will I do to those body parts? I will neglect them, right? I will not take care of them because in my world, those body parts don't exist. So that leads to one more manifestation called as hemi-neglect. So examiners can also ask you, hemi-neglect is due to lesion of which part of the brain, right? It is also a manifestation of non-dominant parietal lobe lesion. If you Google out, you will find a lot of images where the patients who are having damage to the non-dominant parietal lobe, when you look at them, what you will notice is one half of their body, they're aware of its existence, so they have taken care nicely. The other half, they don't know it exists, so they have not shaved on that side. The unkempt, the clothes are all filthy. This is what we call as hemi-neglect, which is due to lesion of the non-dominant parietal lobe. Okay, so we're done with frontal lobe lesion. We're done with the parietal lobe lesion. Now moving to the temporal lobe. Temporal lobe and frontal lobe act in sync and they play a crucial role in the memory. So if there's a damage to the temporal lobe, you can have memory dysfunction. The example I can quote is Alzheimer's disease, where the temporal and frontal lobes generally go through neurodegeneration. The cholinergic neurons in the temporal lobe and frontal lobe degenerate. That is why you have loss of memory. Mostly in Alzheimer's disease, the problem starts in the temporal lobe. There is the entorhinal cortex where the problem starts. And then the degeneration eventually includes the frontal lobe. That is why the starting symptom is memory loss, the short-term memory loss. As the condition progresses, when the prefrontal cortex also there is degeneration of the neurons, patients start developing behavioral and personality changes. So behavioral and personality changes and memory loss are part and parcel of the various dementia conditions. One example I gave you, that is Alzheimer's disease. There's one more example, which we call it as frontotemporal dementia, right? Frontal lobe, temporal lobe, both are getting degenerated. In those patients, the earliest site where degeneration starts is the frontal lobe. That's why we call it as frontotemporal instead of calling it as temporofrontal dementia. So their earliest symptom is not the memory loss, rather personality and behavior changes. And as the time progresses, the memory gets affected once the temporal lobe is involved. In case of Alzheimer's, reverse, memory first, then the behavior and personality changes. Okay, so this is about your temporal lobe. Right now, we will not get into the occipital lobe because occipital lobe's primary function is visual interpretation and visual perception. We will do that discussion integrated with the ophthalmology, starting from the causes of blindness from the cornea till the retina to the visual cortex. Okay, so this is localization of lesions or how we can clinically diagnose which lobe or which part of the brain is affected based on the symptoms, right? So again, to give you a summary, prefrontal cortex, personality and behavior changes, right? Motor cortex, hemiplegia, loss of voluntary movements. Premotor area, important point to remember is truncal weakness and frontal release signs, right? Then the somatosensory area and the sensory association area on the parietal cortex, the lesion will cause loss of cortical sensations, right? Astereognosis, agraphesthesia, loss of tactile localization and tactile discrimination, those ones. Dominant parietal lobe marginal gyrus lesion will lead to motor apraxia. Angular gyrus lesion will lead to Gerstmann syndrome. Non-dominant parietal cortex lesion will lead to loss of ability to construct or loss of construction skills, and it will also lead to the anosognosia and hemi-neglect. Temporal lesion can lead to loss of memory. Okay, so this is the interpretation of different neuroanatomy and its clinical correlation. Now we will proceed further, and that will, whatever we are going to learn next is also going to help us make a neurological diagnosis. Over to you, sir.
Thank you, sir. Thank you, sir. Very well explained, sir. Very nice explanation. Okay, so now we come to the various tracts that carry the sensation towards the brain. So first, let us discuss about this
Yes.
about the sensory pathways. the crude and the fine sensation, how does it go to the brain? Okay, the crude and fine sensations, how do they go to the brain? And then we go to the fine sensations. So crude sensations like touch, pain, temperature, and pressure. Is there a noise coming? Touch, pain, temperature, and pressure. Now, how does this sensations go to the brain? Now, this pain and temperature is carried by the lateral spinothalamic tract, and the touch and pressure is carried by the anterior spinothalamic tract. Let us just understand this. I'll draw a slide for you. Look, this is the section of the spinal cord. That's a dorsal root, the ventral root, the spinal nerve. That's a dorsal root ganglion, which has got pseudo-unipolar neurons. So these are the receptor. So there are different orders of neuron. The first order, the second order, the third order neuron. It's like a relay race. The person is running, he hands a thing to the other person starts running. So let us start with the crude sensations first. Crude sensations. From the receptor we begin. The fibers enter the spinal nerve and now they go to the dorsal root ganglion. The dorsal root ganglion becomes the first order neuron for crude sensations. The dorsal root ganglion, that's the first order neuron for crude sensations. From here, the fibers would now enter the gray matter of the spinal cord. In the dorsal horn, there are various nucleus. There are 4 nucleus. One is substantia gelatinosa. Next is nucleus propriosus. Next is nucleus dorsalis, or the class column. And the fourth one is visceral afferent nucleus. So the first order neuron is the dorsal root ganglion. The second order neuron is here. This is the substantia gelatinosa. Substantia gelatinosa. The fibers now cross to the opposite side, and this is what we call as the lateral spinothalamic tract. The fibers now ascend up. The fibers ascend up. Okay, they come to the thalamus. Which nucleus of thalamus is it? It's the ventroposterolateral nucleus of thalamus. And this becomes the third order neuron for crude sensations. The fibers from the thalamus would now enter into this cortex, to this area number 312. But before going to the cortex, they have to cross this V-shaped structure. What is this? That's the internal capsule. So from this thalamus through the internal capsule, the fibers go to area number 312. Area number 312. Okay, so this is the pathway for crude sensations. The first order neuron is the dorsal root ganglion. The second order neuron is the substantia gelatinosa of the spinal cord. The fibers cross to the opposite side and now they start to ascend up. Okay, the third order neuron is the thalamus, the ventroposterolateral nucleus of the thalamus, and through the internal capsule they go to area number 312. Okay, now this is the lateral spinothalamic tract. Understand this anterior spinothalamic tract. Again, from the receptor, this are the fibers which enters the dorsal root ganglion. That's the first order neuron. Then they enter into the dorsal horn of the spinal cord in the nucleus propriosus. That's the second order neuron. The fibers now they go to the anterior aspect. Okay, so this becomes the anterior spinothalamic tract. Anterior spinothalamic tract. The fibers go to the thalamus, again the ventroposterolateral nucleus of the thalamus, and through the internal capsule they go to this area number 312. So how are the fibers arranged here in the spinal cord? The pressure, the touch, the temperature, and the pain from medial to lateral, the fibers are arranged. Okay, so clear with the different orders of neurons. So this is about the crude sensations. What about the fine sensations? Fine sensations, sir has just explained you. Which are the fine sensations? One is tactile localization. If there's a stimulus, we can localize where the stimulus is. So that's tactile localization. If there are two different stimuli, this is you can differentiate between them. That's tactile discrimination. You can identify an object without looking at the object. What is that? Stereognosis. Sense of position in space, that's proprioception. And that is vibration. Tuning fork, that's vibration. So these are the fine sensations: tactile, localization, discrimination, stereognosis, vibration, and proprioception. Now, how does this fibers go to the brain? Again, there are different orders of neuron. Let me just begin this. We start from the receptor. The fibers enter the spinal nerve. They go to the dorsal root ganglion. Again, the dorsal root ganglion becomes the first order neuron for fine sensations, right? The fibers now directly go here on the dorsal aspect of the spinal cord in the white matter, and the fibers straight away start to climb up. What is this tract known as? This is known as the tract of Gall and Berta, or this is what we call as the fasciculus gracialis and fasciculus cuneatus, or this is also known as the dorsal columns. So now the fibers are ascending up from the spinal cord. They go up, they reach the medulla, they ascend on the dorsal aspect of the medulla. In the medulla, we've got two nuclei by the name of the nucleus gracialis and nucleus cuneatus. So where is the nucleus gracialis and cuneatus located? In the medulla on the dorsal aspect. So fibers will relay here. This becomes the second order neuron for fine sensations, the nucleus gracialis and nucleus cuneatus. Now the fibers cannot ascend above this because here the medulla opens up and there's a cavity here. That's the fourth ventricle. So the fibers cannot climb above this because there's a fourth ventricle here. So what do the fibers do now? The fibers now cross to the opposite side and they start to climb up. And this tract is what we now call as the medial lemniscus. Medial lemniscus. And this crossing of fibers is what we call as the internal arcuate fibers. Internal arcuate fibers, or this is also known as the sensory decussation. Sensory decussation. So fine sensations, the first order neuron is in the dorsal root ganglion. The fibers straight away climb up, reach the medulla. The nucleus gracialis and cuneatus becomes the second order neuron for fine sensations. The fibers cross to the opposite side, the internal arcuate fibers. They now climb up as the medial lemniscus comes to the thalamus. Again, the nucleus is ventropostrolateral nucleus of thalamus, and through the internal capsule, they reach this area number 312. So this is the pathway for fine sensations. Clear? So this is the crude and fine sensations. These are the different orders of neuron. And there are some fibers which carry unconscious proprioceptions to the brain, to the cerebellum, and these are the spinocerebellar tracts. Spinocerebellar tract. Again, the first order neuron becomes the dorsal root ganglion. The second order neuron becomes, yes, the Clark's column or the nucleus dorsalis. The fibers, they climb up, and this is what we call as the posterior spinocerebellar or the dorsal spinocerebellar tract. They reach the medulla, and through the inferior cerebellar peduncle, they enter the cerebellum. So this is the posterior spinocerebellar or the dorsal spinocerebellar tract. Again, the first order neuron is in the dorsal root ganglion. The second order neuron is in the Clark's column. The fibers ascend up, enters the cerebellum through the inferior cerebellar peduncle. Okay, and there's one more pathway which is known as the anterior spinocerebellar tract. Again, the first order neuron is the dorsal root ganglion. The second order neuron is the nucleus dorsalis or the Clark's column. The fibers now cross to the opposite side. They ascend up to the midbrain and they enter the cerebellum through the superior cerebellar peduncle. They again cross to the opposite side. That means they innervate the same side. They carry sensations towards the same side. First they cross, and once they reach the cerebellum, they again cross to the opposite side. Okay, so that is the anterior spinocerebellar or the ventral spinocerebellar tract. Okay, so these two spinocerebellar tracts would carry the unconscious proprioceptions. So these are the ascending tracts. Descending tracts will come to it. What do you say, Dr. Santosh?
So we'll complete the descending tract also. Then we will.
Okay, I'll finish the descending tracts also. Now,
yes,
descending tracts are. There's a voice which is heard.
Yeah.
Okay, so descending tracts, one is corticospinal and the other one is corticonuclear. So where does the corticospinal tracts begin from? The corticospinal tracts begins from area number 4. Area number 4, they also begin from 6 and 8, and some fibers are also contributed from 3, 1, 2. From the cortex, the fibers now they are descending down. So first they would enter into the internal capsule. Which limb of the internal capsule do the corticospinal fibers lie in? They lie in the posterior limb. So that's a posterior limb. Okay, I'll make it like this. That's an internal capsule, posterior limb. Internal capsule, the posterior limb. Now, from the internal capsule, the fibers will descend down into the brainstem. So first comes the midbrain. Now, which part of the midbrain do the corticospinal fibers lie? This is very important, students, because we get lesions of the brainstem. So when there's a lesion of brainstem, this corticospinal fibers would be involved always, leading to a contralateral hemiplegia. And at that part of the brainstem, there would be a nucleus of cranial nerve, and that cranial nerve nuclei would be affected. So that is how we get various brainstem lesions, right? So the fibers would be passing through the midbrain. Now, which part of the midbrain do the corticospinal fibers lie? They lie in the, I'll write it as midbrain, they lie in the crus cerebri of the midbrain. Okay. From the midbrain, the fibers come to the pons. Now, which part of the pons do the fibers lie? The basilar part of the pons, basilar part. And if you know now, the various cranial nerve nucleus which are located in the pons. So if there's a lesion of the pons, if there's a vascular injury, vascular lesion, so the corticospinal fibers would be involved, and that cranial nerve nuclei will be involved, right? Now, the fibers now come down to the medulla, and in the medulla, they cross. And where do they lie in the medulla? Pyramids. They form elevations which are known as pyramids. They cross. 85% of the fibers cross in the medulla. 15% do not cross. They descend straight down, but later they cross at the level of spinal cord. And some 5% do not cross, right? So 85% of the fibers cross in the medulla, and now they go to the spinal cord. Spinal cord, where do they relay on? The anterior horn cell of the spinal cord. So now this from the cortex to the anterior horn cell, what do you call this as? This is the upper motor neuron. From the anterior horn cell, what begins is the motor nerve, and that motor nerve would constitute the lower motor neuron. Okay, so upper motor neuron is from the cortex to the anterior horn cell, and the anterior horn cell and the nerve which begins from there becomes a lower motor neuron. Okay, so UML paralysis, LML paralysis, that's how I'll be telling you. So that's about the corticospinal tracts. Clear to all of you? Fine, sir?
Yes, sir. So let me take it forward from there. So what you've learned, guys, first thing you learned is that spinal cord is mainly a conduit for the information to go to the brain from your periphery, and the information to come from the brain to your periphery. So it is a to and fro conduit, right? So in the spinal cord, you have one major descending tract, which is the pyramidal tract, right? As a physician, I would like to call it as pyramidal tract, which is nothing but the motor tract. The journey of the neuron starts in the motor cortex, and then it will descend through the brainstem into the spinal cord. And as sir told, at the base of the medulla, the major fibers from this pyramidal tract are decusating to the opposite side, and then they will continue to descend down on the lateral aspect of the spinal cord. And at multiple levels, these neurons will synapse with the next order neuron, whose cell body is called as anterior horn cell, and that comes out as the spinal nerve to supply a particular muscle. Okay, now let us look at this entire structure. If I do damage to the motor cortex, what will be the result out of it? If I do damage to the motor cortex, let me say right-sided motor cortex. So the right-sided motor cortex is giving the motor inputs to the left half of the body, because whatever that originates on the right side is crossing to the left at the base of the medulla. So if I do damage to the motor cortex, it will cause hemiplegia, left-sided weakness, right? Similarly, if I do damage to the pyramidal tract anywhere in the brainstem, what is the symptom? Same, hemiplegia, right? On the opposite side, contralateral hemiplegia. If I do transection of half of the spinal cord, I'm doing damage to the pyramidal tract. What will be the result? There can be loss of the motor function. But when it comes to spinal cord, the loss of motor function will be on the same side. Why? It will not be on the contralateral. Whichever side I've cut it, the loss of function will be on the same side. Reason for that is the tract is already decussated and it is running on its own side. The decussation has happened at the base of medulla and it is running on its own side. Clear? Okay. So now, whenever you hear the word hemiplegia, that means the possibility of lesion is either in the cerebral cortex or in the brainstem, and between the cerebral cortex and brainstem, there are structures which constitute subcortex. The most important component of the subcortex is internal capsule. Sir has already told you that sensory tract is passing through it, so is the motor tract in the posterior limb of the internal capsule. So hemiplegia can happen because of the cortical lesion, subcortical lesion, and brainstem lesion. So as a clinician, my job is to identify whether this hemiplegia is because of the cortical lesion, whether it is because of the subcortical lesion, or whether it is because of the brainstem lesion. It is pretty damn easy to identify the lesion of the brainstem causing hemiplegia. Why? Because in the brainstem, apart from the ascending sensory tracts and descending motor tracts, we also have cranial nerve nuclei. So if there is a lesion of the brainstem, it may involve the cranial nerve nuclei. So apart from hemiplegia, we will also have cranial nerve deficits. And you guys should tell me, when the cranial nerve is involved in a brainstem lesion, whether the cranial nerves will be involved on the same side as hemiplegia or the opposite side. So as sir has told, the motor pathway is decussing at the base of the medulla. So in the brainstem, it is representing the other side of the body. So if I cut it, it is going to cause contralateral hemiplegia. But the cranial nerve nuclei, whatever the cranial nerves originate from those nuclei, they do not decussate to the opposite side. They supply the same side. So if there is a brainstem lesion causing hemiplegia, it will be accompanied by ipsilateral cranial nerve palsy and contralateral hemiplegia, right? What we call this as? We call it as crossed hemiplegia. Ipsilateral, same side, there is cranial nerve palsy. Opposite side, there is hemiplegia, crossed hemiplegia. Typical MCQ, crossed hemiplegia indicates lesion of which part of the central nervous system? It indicates brainstem. Now let me pose one more question. If I tell you which cranial nerves are involved along with hemiplegia, can you predict which part of the brainstem is affected? Is that possible? Very much possible, right? Because brainstem has three components: midbrain, pons, and we have a medulla, right? Now we know that there are 12 cranial nerves, out of which cranial nerve 1 and 2, we know their functions. Where are they located? The remaining 10 cranial nerves hold their nuclei in the brainstem. For simplistic reason, we can take pons as the center point of the brainstem, and we can say there are 4 cranial nerve nuclei which are above the level of pons, 4 at the level of pons, and 4 below the level of pons. Forget about 1 and 2, right? We know where are they located. So remaining 2 out of the 4 are located above the pons. That means in the midbrain. What are those? Cranial nerve number 3 and 4. So if there is a third or fourth nerve palsy plus hemiplegia, you can say the lesion is in the midbrain, right? Similarly, cranial nerve nuclei 5, 6, 7, 8, they are present mainly in the pons. So if there is a lesion of the pons, you can have any of these cranial nerve deficits along with the contralateral hemiplegia. Similarly, the remaining 4 cranial nerve nuclei are there in the medulla. So if there is a medullary lesion causing the hemiplegia, the cranial nerve involvement may be affecting the last 4 cranial nerves. So looking at which cranial nerves are affected, we can identify whether the lesion in the midbrain, pons, or the medulla. Number 1. Second, based on the examination, we can also determine the side of the lesion. Side of the lesion will always be the side of cranial nerve involvement because the tract decussates. So hemiplegia will be always on the opposite side of the lesion. Cranial nerve involvement will be on the same side of the lesion. So to give you an example of Weber syndrome, you have a third nerve palsy. Let me say patient has got right third nerve palsy and left hemiplegia, right? So where is the site of lesion? We have crossed hemiplegia. It has to be brainstem. Third nerve nuclei is there in the midbrain. So patient has got a midbrain lesion. Now which side? I said patient has got right cranial nerve palsy left hemiplegia. If I say so, then that means right is the side of the lesion. Or if I say left cranial nerve palsy and right hemiplegia, then left is the side of the lesion. So looking at which side of the cranial nerve are affected, we can identify the site. And looking at what number cranial nerve is affected, we can also identify the site within the brainstem. Okay, now let me go a little up. We have subcortex, and above the subcortex, we have the cortex. Now, what is the arrangement of fibers here? In the cortex, fibers are widely spaced out, right? Like a lot of bed cells or your cell bodies of your motor neurons are present in the cortex, and all those axons cluster together and to form a tract. And by the time they reach internal capsule, they're all compacted in a very small area. Now, one of the standard way of identifying the cortical versus subcortical stroke is whether it is a dense hemiplegia or less dense hemiplegia. You guys should tell me whether the cortical stroke is going to be dense hemiplegia or a subcortical stroke is going to be dense hemiplegia. What do you think? Okay, imagine 1 centimeter area of the brain being affected with stroke. 1 centimeter area in the internal capsule, which is representing our subcortex. 1 centimeter stroke in the motor cortex. Which one is going to cause more damage or more number of neurons are going to be damaged? Whether is it in cortex or subcortex? Obviously subcortex, right? That is where all your tract is condensed. So a subcortical stroke generally presents with dense hemiplegia. Cortical stroke is going to be less dense. Clear? Now, the second thing is sometimes, like I typically use the word differential hemiplegia. Now, what do I mean by differential hemiplegia? Now, hemiplegia means one side of the body is weak, but the weakness need not be uniformly distributed. There can be more weakness of the face and upper extremity in comparison to lower extremity, or vice versa. Lower extremity can be profoundly weak in comparison to face and upper extremity. We call it as differential hemiplegia. One side, one extremity affected more than the other. Will that differential hemiplegia suggest you a cortical stroke or a subcortical stroke? What do you think? Right, in one of the lesion, subcortical or cortical, in one of the lesion, face, arm, and lower limb are equally affected. And in another location, either you have face and arm predominantly affected than the lower limb, or the lower limb is predominantly affected than the upper limb and face. So for that, I think we need to understand motor homunculus. So Pradeep sir was talking to you about the distribution, right? So if you look at the motor homunculus or the distribution of representation of the different body parts on the brain, then you will notice that the lateral surface of the motor cortex is where face and arm is predominantly represented. And on the medial surface and on the superior surface is where your lower extremity is represented. So there is a widespread distribution of all these cell bodies from which the neurons are coming down. So if I cause a damage to the like, let me say the superior or the medial aspect of the motor cortex, I'm most likely to damage the fibers going to the lower limb. On the other hand, if I do damage to the lateral aspect of the motor cortex, I'm more likely to damage the fibers representing the face and upper extremities, right? So in that case, can I say that cortical stroke has a differential weakness? Pretty much right? So in cortical weakness, either face and upper extremity is affected more than the lower limb or vice versa. And is it possible for us to identify which blood vessel may be responsible for this differential weakness if it is a cortical stroke? Pretty much likely, right? If you remember, Pradeep sir showed you about the blood supply. So I already told you that it is the lateral surface where the face and your arm is predominantly represented, which is getting the blood supply from which artery? It is getting the blood supply from the middle cerebral artery. So if a patient presents with face and upper limb weakness more than lower limb weakness, mostly he has got cortical stroke. Two, mostly he has got a stroke because of the MCA territory block, right? A block in the middle cerebral artery. On the other hand, you have one more patient who also has differential hemiplegia, but here the weakness of the lower limbs is more profound than the upper limb and face. Where is the representation of the lower limb? To some extent on the medial surface and a little bit on the superior surface of the motor cortex, which is receiving the blood supply from where? Mainly from the anterior cerebral artery, as you see in the image. So if there is an anterior cerebral artery block, patient will present with hemiplegia, where the lower limb is much more weaker than the upper limb and face. Now you might ask me, sir, how would I identify which one is profoundly weak in the question as well as in a real world scenario? Simple, guys. If it is a question, the examiner may tell you that upper limb and face are more profoundly weak than lower limb, or instead what he will tell you is he will give you the power of these individual group of muscles or limbs. So if he says that, okay, the power in the upper limb is 4 out of 5 and the power in the lower limb is 2 out of 5. Hemiplegia, both the sides is weak. I mean, both the limbs are weak, but upper limb is less weak, 4 out of 5. Lower limb, he has mentioned 2 out of 5. That means lower limb is more weak. What does that indicate? Lower limb weakness is more than face and the upper limb. So in that case, what is the culprit blood vessel? Mostly anterior cerebral artery, right? Okay, so this way we can localize a cortical stroke versus subcortical. Now, subcortical, what happens is all these fibers have come together, you do damage, then everything will get equally affected. Face, arms, and lower limb equally affected. Non-differential hemiplegia. Differential hemiplegia, cortex. Non-differential dense hemiplegia, subcortex. There can also be other potential clues. So sir did talk about the Wernicke's area. He spoke about the Broca's area. These are all part of the cortex or subcortex. They're part of the cortex, right? So if there's a hemiplegia with speech disturbance, it goes without saying that patient has got a cortical stroke because all these speech areas are part of the cortex. We did not discuss in the internal capsule. We spoke about it when we were talking about different lobes or cortexes of the brain. That can be a potential clue. Then higher mental functions, right? Higher mental functions are not the functions of your brainstem. They're not the functions of your subcortex. They are the functions of your cortex, right? Your frontal lobe, prefrontal cortex. So higher mental functions are the functions of that area. So if patient has got stroke, hemiplegia, and along with that, he has got altered sensorium or he had an episode of loss of consciousness. It means higher mental functions are altered. That also goes in favor of the cortical stroke as a lesion. So it is possible for us to clinically differentiate, at least with reasonable confidence, whether the hemiplegia is because of a cortical lesion, subcortical lesion, or whether it is because of the brainstem lesion, right? Okay. We will also discuss a little bit about the spinal cord level of localization in the spinal cord when we do an integrated session with ortho as well as surgery. So for now, this gives you a fair idea about how to make a localization of lesions of the brain, cortex, subcortex, and the brainstem. Sir, you would like to add anything?
Very, very well explained. Very nicely explained, sir, and in a very simple way. I liked it, sir.
Thank you, sir.
Very nice. I hope everything will be clear for the students.
Hope so, sir. Sir, shall we take one of the questions so that students get to know how to cut through the information and take out with the question. So we will share one of the clinical vignettes, sir. I think I had shared a PPT with you, sir. If you can project that, I will just read it out for the students.
PPT, I think I must be having it here.
Or I will just read out the question, sir. You can just write it down. Okay, so I think we will read out the clinical vignette 2 that I had shared. That will clinical vignette 2 we will discuss, sir. In the subsequent sessions, we will discuss the other vignettes. So in this vignette, we have a 45-year-old who presented to us with inability to carry out simple calculations such as addition, subtraction, and he also has inability to write. He has inability to write the language which he has already learned. Nobody is asking him to write gibberish language which he has not learned. And when the physician examined him, it was noted that patient has difficulty in distinguishing between left and right. तो ये वो हो गया ना, वो फिल्मों में होता है, तेरा left या मेरा left, that kind of a confusion patient is going through on the examination table. Now the examiner is asking you the lesion in which of the following brain structures explains this clinical case. The first question is, the question is very straightforward about a syndrome. So identify what is that syndrome, and then we will discuss a little bit about it. Options that are mentioned in the question are prefrontal cortex, whether it is a lesion of the prefrontal cortex which explains this case, or whether it is the lesion of the dominant parietal cortex which explains this case, or whether it is the lesion of non-dominant parietal cortex that can explain the case, or the last one, temporal lobe. Where is the lesion so that patient develops cluster of these symptoms? So guys, what is this syndrome? I introduced this syndrome to you a couple of minutes back. So what is this syndrome? What is a syndrome? This is nothing but the Gerstmann syndrome, right? What is Gerstmann syndrome? Gerstmann syndrome is clustering of symptoms described as acalculia, difficulty in carrying out simple calculations. Second, agraphia, difficulty in writing, right? Third, left-right confusion, right? Okay. So these are the symptoms which describe our Gerstmann syndrome. Patient has got those manifestations. Now, the question can also be translated into a one-liner asking Gerstmann syndrome is due to lesion in which of the following structures. Now that it is the era of NExT, instead of giving you one-liner question, they will give you a story. The interpretation of this story is patient has got Gerstmann syndrome, right? He has got acalculia, agraphia, alexia, and left-right confusion, which is due to lesion in the angular gyrus, which is part of the cortex. Now, which part of the cortex? Is it the dominant parietal cortex or the non-dominant parietal cortex? Angular gyrus is in the parietal cortex, right? Dominant or non-dominant. This distinction we did, right? What did I tell you? The sensory area and sensory association areas are predominantly active on the dominant parietal cortex. So is the marginal gyrus, and so is the angular gyrus, right? So the function of this sensory and the sensory association areas is to give you a higher understanding of your primary sensations or peripheral sensations. We call them as cortical sensations. Damage to this area can lead to loss of cortical sensations. You can have stereognosis, all of that. Marginal gyrus lesion will lead to apraxia, right? Angular gyrus lesion will lead to Gerstmann syndrome, right? So it is a manifestation of dominant parietal lobe lesion involving the angular gyrus. If the non-dominant parietal lobe is involved, two important things I ask you to remember. Number one, loss of construction skills, and number two, anosognosia and hemi-neglect, right? Okay. So if I have to go with the other options, just to give you an idea what those lesions are going to present. So if there is a lesion of the prefrontal cortex, what is the change we are going to see? Mostly with respect to personality and behavioral changes and memory disturbances, because that is the function of our prefrontal cortex, right? Then if I have to talk about temporal lobe, again, mostly involved in the memory. So we might have the memory related issues or short-term memory loss if there is a lesion of the temporal lobe. Sometimes a lesion of the temporal lobe, especially the mesial temporal lobe, can cause refractory epilepsy syndrome, what we call as mesial temporal epilepsy. So in this case, nothing suggestive of refractory epilepsy is there. In this case, nothing suggestive of the personality or behavioral changes are there. So I can comfortably rule out option A and B. If at all I'm getting confused between B and C, we have to always remember for the non-dominant parietal cortex, only two things to remember, right? That is anosognosia, hemi-neglect, and loss of construction skills. Rest of the things are the functions of dominant parietal lobe. So keeping that in mind, we will go with the answer as dominant parietal lobe. So guys, what did we learn today? Understanding the functional neuroanatomy helped us to make a clinical diagnosis, right? We have precisely localized. We did not require a CT scan of the brain or MRI of the brain to identify which part of the brain is damaged in this patient. I will definitely, for this patient, I will definitely do an MRI. But the purpose of doing an MRI is not to localize. Localization, if you know the substance well, you will do it clinically. I will do an MRI to see what caused the damage. There is a damage to angular gyrus. That's my interpretation. Whether there is a tumor or whether there is a stroke or there is an abscess, what is causing the damage? For that, I need MRI, right? Otherwise, where is the damage? That can be assessed purely on the clinical grounds. So guys, stay connected with us on these integrated neuro sessions. As we go forward, we will learn more about the neurological diseases. We will begin like this. We will begin with the basic sciences, and we will utilize our understanding of basic sciences to make the clinical decisions with respect to diagnosis as well as management. Pradeep sir, thanks a lot for connecting. I think students had a very good idea about the neuroanatomy. So in one session, probably they could revise anatomy as well as medicine, and hopefully this will also help them when they go to wards and bedside discussions and case presentation.
It was a very interesting session, and normally what happens is we teach more of anatomy, but very less of clinical. So now, listening to the lecture, even I have understood many things.
Yes, sir.
Thank
Even
you.
I could understand some intricate details of the anatomy. So this will also help me better my practice and also the teaching. Thank you, sir. Students, thanks for connecting and stay connected with us on the NExT channel. We will learn more on the neurology in the coming sessions. So tomorrow, one more session lining up. Stay connected. Thank you all, guys. Have a good night. See you soon. Thank you, sir. Thank you.
Good night.